Good afternoon, everyone. Today I will be talking about liver cirrhosis. We know cirrhosis is, by definition, is a chronic progressive disease characterized by widespread degeneration, necrosis, subsequent fibrosis and scarring, and associated with regenerative nodules formation, which leads to loss of liver function. So, both the processes of degeneration, regeneration are occurring. It leads to chronic liver disease. It's a insidious onset, prolonged course. Cirrhosis takes decades of chronic liver disease to develop. This is a classical picture of healthy liver, how a healthy liver looks like, and how a cirrhotic scarred liver looks like. So, the term cirrhosis was first coined by René Laennec to describe the abnormal liver color of individuals with alcohol-induced liver disease. And it's derived from, the word cirrhosis is derived from the Greek word kyros, which means yellowish brown color, which is the color of the scarred, contracted liver seen in cirrhosis of liver. It's a chronic condition, diffuse destruction, fibrotic regeneration, fibrosis and degeneration and the regeneration of hepatic cells. Basically, cirrhosis is a histological diagnosis. Clinically, we can suspect that the patient has cirrhosis of liver, say end-stage liver disease, non-reversible condition. And it is the most common cause of portal hypertension and its complications. Cirrhosis is the 8th leading cause of death. It's an important cause of premature death. It can occur at any age. 20% of patients who have chronic hepatitis C viral infection and hepatitis B virus infection go on to develop cirrhosis, which is called post-necrotic cirrhosis. So, if you see the etiology of cirrhosis of liver, the most common is alcoholic. People who have abused alcohol, drink excessive alcohol, can lead to liver damage. That is very common. In India also viral hepatitis is common, and it is hepatitis B and hepatitis C which is responsible for chronic liver disease and can lead to cirrhosis of liver, which is called post-necrotic cirrhosis. Cirrhosis could be biliary, and there is primary biliary cirrhosis and sclerosing cholangitis, biliary sclerosing cholangitis, which can cause cirrhosis of liver, which is basically obstructive type of picture we get. In patients who have chronic right-sided heart failure, which leads to chronic congestion of the liver, can develop cirrhosis, which is called cardiac cirrhosis, quite rare. Where no exact cause is known, it's called cryptogenic. Non-alcoholic fatty liver disease is now emerging as a very important cause of cirrhosis of liver. Nearly 1/3 of our population are suffering from non-alcoholic cirrhosis, fatty liver disease, which can sometimes progress to cirrhosis of liver. So, it's a lifestyle-driven disease. Another cause of cirrhosis is autoimmune. I will talk about it subsequently. And certain hereditary causes should also be looked for, especially in younger patients. Wilson's disease is a copper storage disorder in which can cause cirrhosis of liver, in addition to degeneration of the lenticular and of the extrapyramidal signs and symptoms may be present, in addition to KF ring in the Descemet's membrane of the eyes. So, we have alpha-1 trypsin deficiency, which can cause cirrhosis of liver, hereditary cause, which can also cause emphysema in the younger age group. Hemochromatosis is an iron storage disorder, which is also called bronze diabetes, which can also cause cirrhosis of liver. So, alcoholic cirrhosis, the most common cause, also called Laennec cirrhosis, in which micronodules are formed, and small nodules of the size of 1 millimeter are there on the surface of the liver. And patients, and therefore, because alcohol is consumed more by males, it is distinctly more common in males as compared to females. There are 3 stages of alcoholic liver disease. The first stage is fatty liver, which is totally reversible. The second stage is alcoholic hepatitis, where the patient has icterus and tender hepatomegaly, but which may or may not be reversible, and cirrhosis of liver, which is an irreversible stage. And what is risky alcohol consumption? In men, more than 2 drinks per day, and women, more than 1 drink per day is harmful. And what is 1 drink? It is about 45 ml of spirit, 120 ml of wine, or 1 can of beer. And 1 drink basically contains 10 grams of alcohol. So, alcohol consumption is harmful for the liver and causes cirrhosis of liver. Post-necrotic or post-viral cirrhosis, also called macronodular cirrhosis or toxin-induced cirrhosis, most commonly because of hepatitis B and C hepatitis, and that is more common in women as compared to males. Very quite common, the hepatitis B and C infections are quite common in India. Biliary cirrhosis results from primary biliary cirrhosis or primary sclerosing cholangitis are biliary causes of cirrhosis of liver, in which chronic biliary injury and obstruction of the intrahepatic and extrahepatic biliary system is seen, and scarring is seen around the biliary ducts and the lobes of the liver. Cardiogenic cirrhosis or cardiac cirrhosis occurs in long-standing hepatic congestion, which occurs with severe right-sided heart failure with cor pulmonale, which means after COPD, patients may develop cor pulmonale, and that will lead to right-sided heart failure, where the patients have hepatic congestion which may last for a longer period of time and may sometimes, but rarely, can progress to cirrhosis. Constrictive pericarditis and tricuspid insufficiency also lead to chronic hepatic congestion, right-sided heart failure, and that may lead very rarely to cardiac cirrhosis. Cardiac cirrhosis is not a common cause of cirrhosis of liver. There are certain inherited diseases which I have just mentioned. One is mucoviscidosis or cystic fibrosis, alpha-1 antitrypsin deficiency, hemochromatosis, Wilson's disease, and glycogen storage disorders are all inherited causes of cirrhosis of liver. Another important cause of cirrhosis of liver is autoimmune hepatitis, which is caused by the body's immune system attacking the liver cells and causing inflammation. And about 70% of patients who have autoimmune hepatitis are females, and it may cause leukoid hepatitis, and which is seen in systemic lupus erythematosus. And I'll describe this in detail subsequently. Now, what is very important is non-alcoholic fatty liver diseases is now emerging as a very important cause of cirrhosis of liver, because it is fairly common. It's a lifestyle disease, and it's a silent epidemic because it does not, non-alcoholic fatty liver disease does not cause any symptoms, and therefore these patients may only may be detected in an advanced stage. And people are happy because they are not consuming alcohol but are obese, and that leads to fat deposition in the liver, and that might cause alcoholic fatty liver disease, which can subsequently progress to cirrhosis of liver. It's important that by definition NFALD is evidence of abnormal hepatic steatosis more than 5%, either by imaging or histology. But it's important that while defining non-alcoholic fatty liver disease, we need to rule out the fat deposition which occurs because of significant alcohol consumption or because of medications like amiodarone methotrexate or steroids, and hereditary causes like Wilson's and hepatitis T. So these conditions needs to be ruled out before labeling. Any patient who is consuming alcohol are not labeled as non-alcoholic fatty liver disease. Therefore, it's a negative definition. Why is NFALD important? Because it has a very high prevalence. Nearly 1/3 of our population is suffering from non-alcoholic fatty liver disease, and it is the most common cause of asymptomatic liver enzyme elevation. and can lead to cirrhosis of liver. Overall mortality is more than those without NAFLD, and death can occur because of liver problem, but also because of cancers and cardiac problems. The third because important cause of hepatocellular carcinoma. Since NAFLD is a negative definition, a positive definition has been proposed, which is called metabolic associated fatty liver disease, which has been a consensus driven proposed nomenclature of metabolic associated fatty liver disease, diagnosed not by exclusion but inclusion of metabolic factors. And these are the metabolic factors: metabolic syndrome, that is NCEP ATP3 guidelines for diagnosis of metabolic syndrome, which is a clinical definition. Abdominal obesity, that is waist circumference, which is measured between the iliac crest and the costal margin, the maximum diameter usually at the level of the umbilicus. If it is more than 102 centimeters in men and more than 88 centimeters in women, this is called abdominal obesity or waist circumference. But these are Western criteria, and South Asia specific guidelines mention much lower cutoff levels of waist circumference. And as per the South Asia specific, that means in Indians, the cutoff levels are more than 90 centimeters in males and more than 80 centimeters in females. Triglyceride levels more than 150 milligram percent, HDL cholesterol less than 40 in males and less than 50 in women, blood pressure more than or equal to 130 by 85, and a fasting plasma glucose of more than 100 milligram percent. Any three of these five criteria, if they are present, we can label the patient as having metabolic syndrome, and these patients usually have non-alcoholic fatty liver disease. In prevalence, as I can say, in India, the prevalence of non-alcoholic fatty liver disease is nearly 30%, which is very high, and now is a leading and emerging common cause of liver disease globally as well as in India, affects nearly 1/3 of India's population. And this is essentially driven by lifestyle changes, where there is an escalating epidemic of non-alcoholic fatty liver disease and associated with obesity, diabetes, heart attacks, and hypertension. And because of our lifestyle transition, adoption of an unhealthy lifestyle, adoption of an unhealthy diet consisting of calorie-dense food, high fat, and refined carbohydrates, and low in fiber and fruits and vegetables, which leads to obesity and which leads to high blood pressures and dyslipidemia. Unhealthy indulgent lifestyles have now caused a slew of diseases and cause unhealthy teens, and childhood obesity is actually a forerunner of adult obesity and it is responsible for non-alcoholic fatty liver disease. Now, why are Indians more prone to develop non-alcoholic fatty liver disease? And diabetes and insulin resistance, because of their typical phenotype, which is called the Asian Indian phenotype. That means Indians have a typical body composition with unique biochemical abnormalities seen in Indians. This is described as Asian Indian phenotype, is described as thin fat phenotype, which means the muscle mass is less, but the body fat is more. This is also called sarcopenic obesity, which means the muscle mass is sarcopenia, means less muscles. Obesity means more fat. For a given BMI, Asian Indians have higher percentage of body fat, have higher central obesity, have high waist circumference, and have greater insulin resistance, and are more prone to develop non-alcoholic fatty liver disease and diabetes and premature heart attacks. This study actually shows that more than 1/3 have abdominal obesity, and more than 90% of Indians are not involved with recreational physical activity. So whatever the etiology of cirrhosis of liver, it causes diffuse destruction and regeneration and the regeneration of liver cells and formation of fibrous tissue. The destroyed liver is replaced gradually by scar tissues, necrotic tissue yields fibrosis. Cirrhosis causes damage to the liver, and this causes obstruction of blood, lymph, and blood flow, leads to hepatic insufficiency and portal hypertension. But non-alcoholic fatty liver disease or cirrhosis, in fact, is a spectrum. Initially, on the left side, you can see a healthy liver where the fat is less than 5% of the hepatocytes have fat. This may progress in patients who are obese or patients who consume alcohol or who are prone to develop cirrhosis to what is known as non-alcoholic fatty liver, in which patients have more than 5% of hepatocytes have fat. But in this stage is totally reversible. There is no hepatocellular injury. This will progress to non-alcoholic steatohepatitis, where their liver enzymes may be elevated, and patients have not only steatosis, that means fat in the liver cells, but also in addition they have inflammation, and they have ballooning, and fibrosis sets in. This is partially reversible. But if precautions are not taken, this will subsequently develop into cirrhosis of liver. Cirrhosis is a totally irreversible stage where we need to only concentrate on prevention of complications. And of course, these patients would require hepatocellular hepatic transplantation, liver transplantation. Only 7% of patients who develop cirrhosis of liver may go on to develop hepatocellular carcinoma, which will prove fatal. So about the hemochromatosis, 1/3 of patients who have cirrhosis due to hemochromatosis actually develop hepatocellular carcinoma. 15% of patients who have cirrhosis of liver because of hepatitis B infection develop hepatocellular carcinoma, and about 5% of patients who have cirrhosis of liver because of alcohol can go on to develop hepatocellular carcinoma, which can be fatal. It's an important fatal complication. So NFLD is a spectrum. Obesity leads to hepatic steatosis, which leads to non-alcoholic steatohepatitis, with which there is inflammation in addition to steatosis, which may progress to cirrhosis of liver and which might progress to hepatocellular carcinoma. Now, what are the symptoms of cirrhosis of liver? Many patients of cirrhosis liver may be asymptomatic, and that's very important, and they may be detected incidentally by an ultrasonogram or some other investigation done. Sometimes the patients may develop fatigue, which is vague symptom, and pain in the right hypochondrium, but many patients in the initial stages may be totally asymptomatic. And liver necrosis, fibrosis, and portal hypertension develops, which leads to ascites, edema, splenomegaly, and splenomegaly can lead to hypersplenism, which can cause thrombocytopenia, leukemia, and anemia. Patients, because of portal hypertension, will develop varices, that is gastroesophageal varices, hemorrhoids, and which might rupture and cause massive hematemesis or hematochezia. And decrease in bilirubin metabolism would lead to hyperbilirubinemia and jaundice. The later manifestations are basically from hepatocellular failure and hepatic encephalopathy and portal hypertension, and I'll go through them. Now, what is the definition of portal hypertension? Is portal pressure more than 15 millimeters or 20 of mercury, or more than 20 centimeters of water in the portal vein, or the pressure difference between the portal vein and the hepatic vein of greater than 12 millimeters will result in portal hypertension. So, why this occurs is in cirrhosis of liver, because of nodules and scar, they compress the hepatic veins in the liver and causes the blood pressure within the liver to be high, a condition known as portal hypertension. Now, why ascites develops in patients of cirrhosis liver and why edema feet develops? It is because in cirrhosis of liver, the albumin is synthesized exclusively in the liver, which means albumin is, there is no other extrahepatic site where albumin is produced. Liver is the only organ in the body which produces albumin. So, when there is cirrhosis of liver, there is decrease in serum albumin, and with decrease in serum albumin will lead to decrease in osmotic pressure, and this will allow the intravascular fluid from the intravascular space to exude out into the extravascular space, from intravascular to the extravascular space, and cause edema. So, one of the most important causes of edema, feet, and ascites is because of hypoalbuminemia, which occurs because of cirrhosis of liver. And but also it could occur whenever the fluid exudes out from intravascular to the extravascular space, the intravascular volume becomes less. So the stroke volume becomes less, and when the stroke volume becomes less, the renal artery perfusion pressure drops, and this leads to activation of what is known as the RAS system. RAS means RAAS, which means renal angiotensin aldosterone system. So renin is a proteolytic enzyme which is secreted by the macula densa of the juxtaglomerular apparatus, and it converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by an angiotensin converting enzyme. Angiotensin 2 has got two important functions. One is an important vasoconstrictor, but more importantly, it is the most important stimulus for the release of aldosterone from the zona glomerulosa of the adrenal cortex. And this mineralocorticoid, that is aldosterone, causes salt and water retention. That is the main function of aldosterone. And since this is known as secondary hyperaldosteronism, and this results in more retention of salt and water, which contributes to the edema in patients and ascites in patients with cirrhosis of liver. And therefore, while treating patients of cirrhosis of liver, this is important because we restrict salt and water, and not only that, but because there is secondary hyperaldosteronism, we give aldosterone antagonists like spironolactone as the initial treatment for reduce the edema as well as ascitic fluid. Another reason why patients of cirrhosis of liver develop ascites, is specifically fluid collection in the peritoneal space, is because portal hypertension will also contributes to the development of ascites. So this is the basic mechanisms by which ascites and edema feet develop in patients who have cirrhosis of liver. Now, what are the clinical features of chronic liver failure, chronic liver disease? There is worsening synthetic liver function. Most important is prothrombin. Prothrombin is a coagulation factor which is produced exclusively in the liver, and this is decreased in cirrhosis of liver, and this leads to prolonged prothrombin time. When there is prolonged prothrombin time, the patients can develop bleeding manifestations. Low albumin is responsible for edema feet. Albumin, as I've said, is secreted exclusively in the liver. Jaundice, portal hypertension. They can have varices, which is a manifestation of portal hypertension, which can cause bleeding and cause massive hematemesis. Patients can develop hepatic encephalopathy, that means altered consciousness, and ascites develops, and this ascites can be complicated by a spontaneous bacterial peritonitis, and patients can also develop hepatorenal failure. Now, there is a child-pox classification to determine the cause, prognosis in patients of cirrhosis of liver, and there are four important parameters which are included here. Presence of hepatic encephalopathy, that is altered consciousness, and I will describe this in detail subsequently. Bilirubin, if that is elevated in patients who have cirrhosis of liver, and there are criteria of defining none, mild, and marked, and given score of 1, 2, or 3. Albumin levels are decreased, and depending on the severity of the albumin, hypoalbuminemia, they can be categorized, given a score of 1, 2, and 3, as is shown here. And prothrombin time is prolonged, and depending on the severity of the prolonged prothrombin time, they are given 1, 2, and 3 points. And presence or absence of ascites, if it is none, mild, or moderate, marked, that means that these points are given, and these points are then, scores are then added up and called the child's pug score, and that will determine whether what is the prognosis of a patient. So prognosis depends on whether a person has developed encephalopathy anytime, how the bilirubin levels are, what the albumin levels are, what are the prothrombin time is, and whether the patient had ascites and whether it was marked or severe ascites present or not, will determine the prognosis in cirrhosis of liver. Now, when you talk of portal hypertension as a complication of cirrhosis of liver, there are other causes of portal hypertension as well. Portal hypertension, the most common cause continues to be cirrhosis of liver, but apart from cirrhosis of liver, there are certain other causes. First is pre-hepatic portal hypertension, which could be pre-hepatic pre-sinusoidal portal hypertension, which is because of thrombosis of the portal vein and due to sepsis or abdominal trauma, including surgery. So, pre-hepatic pre-sinusoidal portal hypertension before it enters into the liver. Within the liver, intrahepatic pre-sinusoidal portal hypertension, the causes when the sinusoids in the liver are affected, pre-sinusoidal intrahepatic causes are schistosomiasis, sarcoidosis, congenital hepatic fibrosis, idiopathic hepatic fibrosis, and certain drugs are responsible for intrahepatic pre-sinusoidal. Now, sinusoidal portal hypertension occurs typically in cirrhosis of liver. It can also occur with polycystic liver disease and also develops with nodular regenerative hyperplasia and metastatic malignant disease. Intrahepatic post-sinusoidal, typically seen in veno-occlusive disease or sino-occlusive disease, in which occurs because of bone marrow transplantation or patients who receive chemotherapy. And post-hepatic, post-sinusoidal is because of Budd-Chiari syndrome, when there is thrombosis of the hepatic vein. When there is post-hepatic, post-sinusoidal portal hypertension, the liver is usually markedly enlarged and tender because there is congestion of the liver, because hepatic veins are the first tributaries of the inferior vena cava. And when the hepatic veins are blocked, which occurs with Budd-Chiari syndrome, because of thrombosis or other causes, it causes congestive hepatomegaly and tender liver is seen. So, these are the causes of cirrhosis of portal hypertension. Now, non-cirrhotic portal hypertension, as I have said, portal hypertension not due to cirrhosis of liver, though rare, it can occur because of portal vein thrombosis, that is extrahepatic pre-sinusoidal, or the cavernomatous transformation of portal vein, or intrahepatic perisinusoidal, which occurs with congenital hepatic fibrosis, schistosomiasis, or sarcoidosis. In these patients, because there is no cirrhosis of liver and there is no damage to the liver cells, albumin production is normal, and because of that, ascites and edema feet are rare, and the patients present with splenomegaly, and patients may have gastroesophageal varices or hemorrhoids, which can rupture and the patient can develop hematemesis. So, this is a typical picture of a patient who has cirrhosis of liver. Patients may have altered consciousness, patient may be confused, delirious, may develop stuporous condition, or may go into coma as well. That is called hepatic encephalopathy. It's a complication which occurs because ammonia is increased in the blood, which can be estimated also. And the secondary sexual characters are decreased in patients who have cirrhosis of liver, and patients will have loss of secondary sexual characters in the form of loss of pubic hairs, loss of axillary hairs, and the testicular atrophy, and gynecomastia in males. In females, it could be because of breast atrophy, and patients will have muscle wasting, will have spider angioma, will have jaundice, and will have caput media. I will come to that subsequently. So, reproductive manifestations are amenorrhea in women, testicular atrophy and gynecomastia in males, along with impotence and loss of libido, sexual drive, which is common in patients with cirrhosis of liver, loss of axillary and pubic hairs. These are the reproductive changes which occur in patients with cirrhosis of liver. This is the typical picture. Here you can definitely see that the patient has a huge bloated abdomen, and there are veins over here which are dilated, and also these bleeding spots because of purpura are also seen. Now, what is purpura? Purpura is basically bleeding in the skin, and you can see over here, if they are very small of the size of pinhead, it is called petechiae. When if they are larger, they are called ecchymotic patches, and they usually occur because of thrombocytopenia, which is a feature of severe liver disease, which leads to portal hypertension because there is a destruction of platelets in the liver. Spider angioma are very common and classical manifestation, not very common, but very classically described with cirrhosis of liver. This is also known as spider nevus. It's common in alcoholic cirrhosis. There is a central arteriole and capillaries which radiate out from there, and if you press this central arteriole over here with the help of a pin, it totally blanches. Typically, spider angiomas are typically described in cirrhosis, in stage liver disease, cirrhosis of liver, especially alcoholic cirrhosis, and they occur in the area which is above the nipple. That means in the area which is drained by the superior vena cava. Palmar erythema, again reddening of the palms, again because of estrogen excess, which can occur in patients who have cirrhosis of liver, also called liver palms reddening, both palms due to excess estrogen. Another important sign which should be elicited in all patients is flapping tremors called hysterexis, in which the patient is asked to extend his arms in this manner, and in a patient who is in encephalopathy will have this kind of tremors which are called flapping tremors. This is a sign of hepatic encephalopathy. Not only seen with hepatic encephalopathy, they are also seen with uremic encephalopathy in patients with renal failure. They are also seen in CO2 narcosis, that is CO2 encephalopathy, which can occur in patients who have chronic obstructive airway disease with acute exacerbation. These patients also can develop CO2 narcosis and encephalopathy, which has to be elicited by extending the wrist and dorsiflexing the wrist, and then the patients will have this kind of tremors which are called flapping tremors. Another important sign is fetor hepaticus, which is because of 6 mercaptans which are released from the breath. So they have a very foul smelling breath. Patients who have cirrhosis of liver have a foul smelling, like a smell of a rotten egg or a rotten fish like smell to the breath. It is a sign that the liver is not doing its job in not filtering out toxic substances in patients who have severe liver disease. And patients, they have jaundice, spider nevi, palmar erythema, purpura, petechiae, and caput medusae. Now, what is caput medusae? Now, caput medusae is around the umbilicus. The veins are being dilated. Large, visible, distended, engorged para-umbilical veins due to severe, it's a sign of portal hypertension. And patients have, if you see the flow, direction of flow in these patients, it is away from the umbilicus. So dilated veins around the umbilicus in a patient who has cirrhosis of liver, in which the flow of blood is away from the umbilicus, is called caput medusae. You can also get dilated veins in the flanks in patients of cirrhosis of liver. And if the veins are dilated in the flanks, they have to be seen in a sitting position or a standing position. They may become more prominent rather than in sleeping position. And there the flow of blood is from below upwards. In this situation, it could be because of inferior vena cava obstruction. If there is a tense ascites, it might cause compression of the inferior vena cava, and that can cause dilated veins in the flanks. So visible veins have to be seen in patients who have cirrhosis of liver with portal hypertension. And if they are dilated around the umbilicus and the flow is away from the umbilicus, that's called caput medusae. And if they are dilated in the flanks and the flow is below upwards, they indicate inferior vena cava obstruction. Portal hypertension clinically can be diagnosed by splenomegaly. If the patient has splenomegaly, is an important feature, sign of portal hypertension, and presence of caput medusae, and also gastroesophageal varices, 3 important signs. So if a patient presents with hematemesis, which is usually because of rupture of gastroesophageal varices and melena, and has got on examination caput medusae and splenomegaly on abdominal, you can safely make a diagnosis of portal hypertension in a patient who has signs of cirrhosis of liver. For complications, we have variceal bleeding, which can cause esophageal again gastric, there's a gastric congestive gastropathy, hypersplenism, ascites, anemia, renal failure, and hepatic encephalopathy. So how to diagnose? I think there are a lot of other investigations which need to be done in patients of cirrhosis of liver. We will discuss the diagnosis and investigations to be done in cirrhosis of liver regarding the etiology of cirrhosis of liver in my next talk. Thank you very much for your attention.